and get started. Can you guys hear me okay? Where's my chat? Okay. We can't do trauma. We can't do any contrast. Okay. All right. Thank you. Thank you very much for that. I needed that explanation. Can you guys see my screen okay? Okay, very good. All right. Let's get started. Don't forget, put your name in the chat for beginning the lecture, and then again at the end when we're done. Okay. All right, let's get started here. All right, so let's review a little bit from last week. Question 1, and you guys remember how you put your answers in, Q1 and the number of the answer. What are the 3 cardinal principles of radiation protection? I know you guys know this. Very good. Very, very good. That's an easy question, wasn't it? Question 2. It is the technologist's responsibility to ensure that all personnel are shielded from exposures taken in a trauma room. That is very, very true. It is your responsibility because that is our ultimate position. That's what we do. That is what we do. Very good, guys. Question 3. Which alignment of the C-arm, remember I told you this is going to be a question on the registry, I promise you it will. Which alignment of the C-arm will lead to a significant increase in exposure to the eyes, head, and neck region for the technologist? That is correct. That is correct. With the X-ray tube up. There you go. Very good. All right, question 3. What should you do if you slightly brush against a sterile drape in surgery? I know you guys know this. We went over it last week. Speak up. That's right. Report it. Tell someone. Absolutely. Because you know what the problem, the issue could be later on is the patient can get an infection and all kinds of things could happen. That is right. Yes, you must report it. Question 5. What is the minimum distance that should be kept between the sterile and non-sterile areas in the OR? Who remembers the answer to that? 1 foot. Nope, not 6 feet. 6 feet is the length of the cord on the portable machines. It's 1 foot or 12 inches. Yeah, 1 foot or 12 inches. Very good, very good, very good. Question 6. The absence of infectious organisms is the definition for what? Surgical asepsis, disinfected, okay, not disinfected, disinfected, clean or surgically cleansed. That is correct. The answer is A. Question 7. The boost feature found on many C-arm systems slightly increases exposures to the patient and the technologist. Is that true or false? It is very true. And I mean, I think the easy way to remember this, because it says boost, and you would think if it's going to boost something, it's just going to increase it. That is very good. Very good, guys. All right, let's start with week 2 right here. So today we will discuss a few specific surgical procedures, surgical and trauma procedures. The image on the left, this is for a hip pinning procedure. The image on the left, you can see how it is set up. You see one leg is up, the other leg is down. They would be operating on the one that is not up, okay? You can see how the C-arm is set up. and that would be for an AP projection. And for the image on the right, this is a view from the surgical side of how that whole procedure would look, okay? Hip pinning is a surgical procedure done with a C-arm. Typical reasons for this exam: fracture. Patient falls, and especially with elderly patients. You'll need to know how to set up the C-arm to easily perform an AP or lateral projection of the hip on the operating table. I would highly suggest when you get into your clinical environment where you have C-arms, even if you do now, take the time to go and manipulate the C-arm. You need to learn how the locks work, how to rotate it, how to push it in and out, how to save the image, save the last image on the monitor. You really need to know how to do all those things. It's not the time to learn when you're in the middle of a surgical procedure, okay? This is what an AP projection looks like of the hip. You can see with the image in the center where the femoral neck is fractured. The first picture is just basic anatomy of the hip. The one in the center is, again, the surgical neck fracture, and the one on the right shows how the hip is surgically repaired. And this is just with screws, okay? So this is just an AP projection. In the handouts that you will get, I know there are all of these slides that have links to them where you can see how these procedures are done. To actually show this whole procedure, 30 minutes is way too long because we only have an hour in class. So I want you to watch some of these. I'm not going to say all of them, but watch them on your own. Okay. Now, if I show you some of these videos during class, this is just for educational purposes. I just need to make a disclaimer where that's concerned. I don't have any interest in GE or Siemens or anything like that, but that is why, just so you can see how some of these procedures are done. Okay, I don't know if this is going to work today. It has in the past. This is how these 4 different, 3 different, I'm sorry, guys, I can't even talk today. These 3 different images show you how different things are done on a C-arm. If I can, let's see if we can watch the one at the bottom. You guys let me know if you can hear this, okay?
Hello, my name is Rebecca Hannon. I'm a clinical imaging specialist with GEOEC.
And I'm Sean McKenna, at the same time, the imaging specialist for GE Healthcare Surgery. And I'll show you some of the breaks and locks on the C-arm to help you with positioning for your surgery cases. So we're going to go over the locks and breaks on the GE Elite C-arm. So the first one we're going to go over is the actual brake lock of the C-arm. Is the floor lock. You depress the pedal down, it allows no motion forward or backward of the system. When you unlock it, allows complete motion forward and backward. The next one we're going to go over is the steering handle. You turn the steering handle side to side. It allows you to move the system straight sideways, either direction. And then when you turn the handle straight forward, notice the wheels turn back and allows you to move the C-arm forward and backward. Just gives you complete control of the system to be able to move it either direction you want without having to force. From there, we move to the what we call the rig wide lock or pivot lock. You have 10 degrees of rotation either direction. The C-arm rotates sort of in a pivot in an axis form as an arc. So you have to remember, be very careful in positioning using this lock because it moves really easily and it moves 2 directions at one time.
That's important, guys, when a physician is pinning a hip. and he wants to watch the screws go in. So that is a very important.
After this, we move to our in and out lock, which is green on here. They're all color coded. It has 20 centimeters of travel in, 20 centimeters out. So it allows you to be able to maneuver the C-arm straight in and straight out without having to move the whole system. And then we move to our cranial collar, right? Unlocking it allows you to turn the system completely upside down either direction. You can turn it to where you move the detector on the bottom and the X-ray tube on the top. You can do this either direction. And come back to an AP. From there, we move to the gray lock, which is our GE lock, is called our invert or our smart view lock. It also will allow you to turn the system completely upside down, able to put your detector on the bottom. And we'll go over more about the smart view lock and our positioning. From there, we have one of the more common ones, which is the brake for our AP ladder. And it allows you to turn the system to a ladder at 90 degrees. We actually have an extra 5 degrees of understand there to be able to go 95 degrees to our straight AP. And then in our system, we have 55 degrees of overscan. And then we take it back to 0 to straight AP.
Did you guys hear that okay?
Hello, my name is Rebecca Hannon. I'm a
Let's go to the next. Can you hear me now? I guess I should ask. Okay, could you hear the video? Oh, okay, very good. All right, so this next procedure here is a total hip replacement. You will see AP and lateral projections here. The images show a total hip being replaced. The other name, the other name for a total hip replacement would be total hip arthroplasty. The damaged bone and the cartilage is removed and replaced with prosthetic components. The damaged femoral head is removed and replaced with a metal stem. The head is replaced with a stem. And it is placed into the hollow center portion of the femur. And when the doctor does this, he tends to ream out the center of the long bone, and he will take a hammer like a mallet, and he will just beat it in until he gets it where he wants it to be, okay? Yes, you'll see screws and stuff when you see surgery, and you're like, are these the same things they get from Ace Hardware? Yeah, they just might be. The only difference is they're sterile and they are medical grade. These are some of the hip pinning procedures. A hip pinning is a type of surgery to fix a hip fracture. Again, another name for a hip pinning procedure would be fracture repair with internal fixation. Have you guys ever seen patients that have the external fixators on? That happens a lot with children who have bone length issues, and they attempt to lengthen their bones to some degrees. But yeah, when it comes to just the hip pinning procedure, this is just a fracture repair with internal fixation. So the hip pinning use pins, screws, plates, anything that the surgeon feels will help to hold the broken bone together until it can heal correctly. And yes, ORIF stands for open reduction internal fixation. Now, this next procedure we're going to talk about is the lumbar laminectomy. The lumbar laminectomy, you'll see, you'll notice here the image intensifier again is on the top. The X-ray tube is at the bottom in the first image on your left. And this is for the AP projection. The image to your right, you'll see the C-arm is aligned for lateral. The technologist would be on the right side of this image, right in here. So remember, I think last week I told you guys when this happens, that means the surgeon is going to be on the tube side. And we know for a fact that there's increased exposure to the person that's standing on that end. So if you are doing a procedure with an orthopedist, you would ask him to either step back. We know he has an apron on, but you know, he might want to step back to lessen the amount of radiation that he would receive from the x-ray tube. This is a lumbar laminectomy or fusion. This is a common spinal procedure, which involves partial or complete removal of the lamina of the lumbar spine. It can relieve compressions on some of the nerve elements in the spinal cord due to stenosis or just some form of spinal compression. You can kind of see that would be 5. So this would be L4. Looks a little bit smaller, so it seems like it may have compressed a bit there. And this lumbar laminectomy fusion is to repair that type of injury. Here's an image that shows you the different anatomy. The first video here shows a physician, the one at the top on the right, shows a physician positioning himself on an OR table. You will notice when you watch this on your own, because I'm not going to play it here tonight, you'll notice he moves the table up and down. He puts the patient or himself actually in Trendelenburg. He can tilt the table to the right or to the left. So in addition to having a C-arm that can do that, you also have some flexibility with the table itself. So it's a spinal fusion, also called spondylolisthesis, is a surgical procedure formed by an orthopedist or a neurosurgeon that joins 2 or more vertebrae. This can be performed at any level in the spine and prevents any movement between the fused vertebrae. And you can see that on the video at the bottom. I promise you, you guys will get the links to all these videos so you can watch them on your own. 1 hour is just not enough time to watch them all, but I do want you guys to take a look at it. Okay, the next procedure, oops, well, we can, let's see.
Okay, recording.
Okay, can you guys see this? Okay. We'll watch the video. You notice he's tilting the table to the right or to the left. I think he must be bored because he can't find anything else to do except play with the OR table. Let's go to the next. You guys, again, can watch this once class is done. Now we're going to talk about some trauma skull positioning. And I'm so glad to know that you guys do skulls. That is really great. Make certain that you review the anatomy and all the positioning lines for the skull. Like SOML would be the supraorbital meatal line, IOML, LML, OML. Yes, you just need to make certain that you review all of these. Many skull procedures have nowadays been replaced by CT, but I do now on my lashes. That's a good one. That's a good one on my lashes. But it's good to know, on occasion when you have a person coming into the ED for trauma, they will order AP and lateral skull. They will very rarely are sinuses and orbits, EAMs, those are just not done that often anymore. I mean, on occasion, you'll get someone a physician that wants you to do those, but for the most part, you'll probably be doing AP and lateral skulls more than anything. Okay, this is the positioning for the trauma lateral skull. Again, the interpupillary line is perpendicular to the image receptor. The head can't be tilted, and you're going to have a horizontal beam. With this procedure, and if you guys do this, I know that you need to put something underneath the patient's head to lift it off the table so you can get the occipital portion of the skull on these images. This is how the trauma AP is done and how the reverse Caldwell, because it's naturally a Caldwell projection, but when a patient is in a C-collar, you cannot turn the patient over and do a PA projection. So we do a reverse Caldwell. For the AP, you have, with this particular one, they have the OML, the orbital meatal line. It should be parallel. The central ray should be parallel, but if it's not parallel, then you would have to center the central ray. So there again, this is using a lot of critical thinking skills, knowing how to properly perform these procedures and adapting them to your patient. With the patient in a C-collar, you never want to remove the C-collar, move the head or the neck until the C-spine has been cleared. So, the first thing you would have to do before attempting these skull projections is do that cross-table lateral C-spine and have either the emergency room physician or the radiologist clear the patient, and they're the ones that would have to remove that C-collar. This is just a video of how to do this. I will let you guys look at this on your own, how to do this AP Towns or reverse Caldwell procedure. Watch the video. It's 4 to 5 minutes long, I think. Yes, and in this video, the young lady always talks about an angle liner. It's not an angle liner, it's a goniometer. I'm sure you guys have been taught that already. The goniometer, the little device that shows the different angles of the OML, IOML, or whatever. All right. All right, now the routine trauma C-spine projections. You would do a lateral projection with 72-inch SID. You can do an odontoid, an AP odontoid with the patient lying on the table or on a backboard. You could lift the backboard and put an image receptor underneath for the patient. Do an odontoid. You can ask them to open their mouth. They might be able to do that. You can do that AP axial projection. Again, 45 degrees. Central ray is 15 to 20 degrees. It's cephalad to enter at C4, and a swimmer's projection. And this is when you cannot see C7. And I know you guys know all of this stuff. This is a good projection when C7 and T1 is not visible on the lateral C-spine. And if you guys do spines, I'm sure you have done plenty of these. Gosh, this should be simple, guys. All right, and here are the other projections, the AP projection. The other thing that you should know when being tested is just by looking at the radiographs, you should be able to tell what projection it is. So the first one on your left is going to be the AP axial, the odontoid, and that is an absolutely beautiful odontoid. A lateral C-spine, 1, 2, 3, 4, 5, 6, 7, yes, and T1. And that is actually a very, very beautiful swimmer's projection. Let's see, where are we? Know these for the registry, and know them by sight when you see them, what the name of the projections are that you're looking at, okay? Trauma C-spine, this says this is a 1-minute video. I don't know if I want to watch this. Alternate projections when the patient's in a C-collar or on a backboard and you can't, and they can't be moved until the spine is cleared. Just doing that cross table, lateral cervical spine here, and then them showing how to do a swimmer's. You guys know how to do all of this. I feel like I'm just covering stuff, just review.
What great positioning. Cervical.
Go to the next. Again, now we're going to talk about some different types of fractures of the cervical spine. The Hangman's fracture, this fracture occurs when the pedicles of the axis, or C2, are fractured. Bilateral fractures through the pars interarticularis of C2, and be certain that you guys review the anatomy, okay? Review the anatomy. This can be associated, this Hangman's fracture can be associated with traumatic subluxations of C2. The second most common fracture of C2, and it's the most common fracture, most common odontoid fracture. Fractures into the foramen, the vertebral foramen, they're problematic because the vertebral artery and vein pass through the vertebral foramen. So you've got arteries and veins passing through the foramen. So when you have a Hangman's fracture, this can be very, 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 very critical. On the second set of images, you see C2 outlined in red is moved forward, and C3 outlined in blue is moved backwards to some degree. So that's a Hangman's fracture, and it is exactly what it sounds like, a Hangman's fracture. This is how it looks when a person attempts to, I hate to say it, but commit suicide or whatever by hanging themselves. You can see the 4 lines of the cervical spine. You can see the anterior vertebral line, the posterior vertebral line. Then you see the spinal laminar line and the posterior spinous line. Okay, next we're going to talk about subluxations. And I was talking about those lines because all of those lines should be to some degree parallel with each other and in a lordotic type curve. But a subluxation is when one of the spines slips either forward or backwards above the one or the one above or below it. This is because of a ligament tear or a ligament injury. They can be minor or incomplete subluxations or dislocations where the joint surface still touch but are not in the normal relation to each other. Dislocation injuries to a joint that cause adjacent bones to no longer touch each other. So this is a subluxation with anterior displacement. You see how C4 is moved forward, and this is a subluxation with posterior displacement, I'm sorry, where C5 is moved back. Another type of fracture is the compression fracture. This is when the vertebrae can totally collapse, making it shorter in height. The collapse can also cause pieces of bones to press on the spinal cord and nerves. So this a compression fracture is very, very serious. I don't know if you guys may have seen any in some of the work that you have done, but you guys don't do trauma. You just kind of do routine lumbar spines or C-spines. I'm assuming. I'm assuming. Okay, next is a burst fracture. You can see on these MR images, let's see, 1, 2, 3, 4, 5. See 7 here. You can see how this is a type of compression fracture where the pieces go in all directions, and you can see how it has burst right here in the center and also here. A Jefferson fracture is a burst fracture of C1, where the anterior and posterior arches causing axial compression or hyperextension. The C1 is a bony ring, we know that, with two wedge-shaped lateral masses connected by thin anterior and posterior arches and a transverse ligament. So there's different types of Jefferson fractures and severity of Jefferson fractures. And of course, the type 3 is the worst of all. Oh, question number 8. Cervical spine fractures and subluxations or dislocations must be ruled out before attempts are made to move or manipulate the patient's head or neck. Very good. That is very, very, very true. All right, the next thing we'll talk about, it looks like we'll get done before 7:30. Is the chest, trauma chest. You have the thoracic viscera, where you have surrounded by the walls of the thorax, you have the heart, the lungs, the organs of respiration, the cardiovascular and lymphatic systems, portions of the esophagus and the thymus. So that's part of the thoracic viscera. For the bony thorax, we have sternum, rib cage, clavicle, and scapula. Are you guys able to perform those procedures? Can you do sternums, ribs, clavicles, and scapula? Oh, wow. So the only thing you don't do is fluoro. Wow. I can see why you guys want to go back and finish your LMRT up to be an RT. Yeah. Wow, you guys work hard. I can see that now. All right. For the portable chest x-ray, we need a 40-inch SID, 14 by 17, and the image receptor can either be a landscape or it can be portrait, depending on the size of your patient. The top of the image receptor should be just above the top of the shoulder. Image receptor is parallel to the x-ray tube. And that is very, very important when performing a portable chest procedure. Again, I am not endorsing anything. The video at the bottom is a really good one of how to perform this. And I hope you guys can hear it. I'm sorry, guys. You can watch the rest of this video. It's a Carestream, and that is a nice digital DR type for digital portable machine. It also shows how the patient the tooth is terrible. That is just so neat to me to see how they can actually tell if the image receptor is parallel with the X-ray tube. That is pretty darn neat. I mean, you know, I come from days and times when we did where there were still dark rooms. So I guess I'm dating myself a little bit. For the trauma chest procedure, this video is like a 4-minute video we're not going to watch. When you have a patient that can't stand or sit up, the patient, something important for you guys to know, the patient should always lay in this position where we're doing this left lateral decubitus for at least 5 minutes prior to the exposure. And this is so the air can rise and fluid and ascites can sink to the bottom. And you can see that on this image here. You see this very distinct line. There's fluid or something down here. You can see this distinct line here at the bottom, where fluid would be down at the bottom on these two images. Trauma chest imaging. Okay, these are other procedures, and I think there will be handouts that cover these. For a fractured sternum, you do an RAO or an LPO and a lateral projection. And you know, you can do these with the patient on a backboard. So, you know, you can do the cross table and you can do an RAO. You can angle the tube and move the image receptor to the right or to the left to get that RAO. For fractured ribs, you do unilateral or bilateral, and then you have to do upper and lower. If a patient has pulmonary embolism, if that is their potential diagnosis, CT and nuclear medicine are the modalities for you to perform in order to see that specifically. For pneumothorax, do a decubitus film. I will send you a link for the sternum and the ribs. Okay. Oh my gosh. Oh my gosh. All right. The study guide for quiz 2. These are the procedures that I need you to understand. And since you guys are telling me that you've already, that you're very familiar with this should be simple. Now, when you study for these different procedures, you need to know what the breathing instructions are, how the central ray is directed, what SID you should use, what projections. You should know all of these different things, what breathing instructions the patient has to have. Do they take in a deep breath and blow it out, or they take in a deep breath and hold it? And you need to know that for this chest, the C-spine, the lateral decubitus image, C-spine fractures, AP projection of the ribs. Not just AP projection, but you do unilateral or bilateral upper and lower. Sternum projections, the lateral swimmers. What is the name of the lateral swimmers projection? Does anybody know? How to diagnose a pulmonary embolus. We just talked about that a second ago. What is the method name of the lateral swimmers projection? Come on, guys. I know somebody knows that. And how to use a grid versus non-grid projection. You guys don't know? No. It has a method. Twining. That's it, Jessica. It's the twining. It's the twining method. There you go. It's TWINNING. Very good. Very good. All right. Gosh, I can't believe I was thinking the class was going to go a whole lot longer. We still have 15 minutes left. Yes, that is right. We still have 15 minutes left. Does anybody have any questions? Questions? No questions? You can put your name in the chat. All right, put your name in the chat. I'll make certain that you get the handouts I was talking about so you can study for this week's quiz. If you have any questions before we meet again next week, I do when you are in the OR, you ask the surgeon, hold on, I missed it. Ask the surgeon to switch. Do they actually? Yes. Communication is a big thing when you're in the OR. Yes, if you ask them to, they will. And, they develop very good rapport with people. If you are the regular person that goes to the OR, sure they do. Oh, yeah. And if you tell them why, sure, they'll move. They will. There are always exceptions to that rule, though. But yeah, for the most part, they will. Does anybody have any questions? Questions? Okay, I don't see any questions. I'm gonna stop recording. And as soon as this is done, as soon as this is finished processing, I will post it again in the weekly modules and also send it to you as an announcement. And if you have any questions between now and then, feel free, reach out. I look forward to talking to you guys or chatting with you guys or answering your emails. Okay. Thank you guys. Have a good evening.